Goodness, what can I say after that session? It almost feels like a anticlimactic moment for me. And I'm not going to try and actually, what Scott and Salman had asked me to do, which is an impossible task, and I won't even attempt it, is to try and provide a summary of this meeting. And in fact, that's why I was giving closing remarks. And instead, I told Salman I can't possibly do that. But instead, I'll just provide my own personal reflections. And I thought I'd begin by actually declaring my own positions, my own biases, if you wish, and where I come from. So the first position to say is that I come from a very strong history of being inspired by people like Antya, who Rama invoked. He is one of the great surgeons of India who actually wrote a book, curiously for a surgeon, called People's Health in People's Hands. And I remember this very well because it was a book that was profoundly influential to me. But I was also surprised, how would a plastic surgeon, who I thought would be more concerned with cosmetics, actually write a book such as this? But of course, he wrote this because he was working with people affected by leprosy, the kind of community of people who historically plastic surgeons would never go near. And the book was very powerful. I'd encourage you all to read that, but it really spoke to the conversations we've had here about the need to acknowledge social drivers and social justice as a very important driver of health inequalities. But at the same time, over my career, having encountered World Bank economists at, unfortunately, quite an early stage of my career, I also became involved with the Disease Control Priorities program. And in fact, in their very last avatar of the Disease Control Priorities, I actually led the working group that was examining interventions to be promoted in the area of mental health problems, neurological disorders, and substance use disorders. So I've really sat in both of these camps, and I'm going to try and just draw on my experiences, and they're really not structured in any particular way. They're really experiences that I've reflected on as I've heard this incredible 1.5 days of conversation. The first thing that I wanted to say was that I think we've been presented with what I think is a Faustian bargain. Is it social justice that we should be focusing on, or is it health services that we should be focusing on? And I think no one in this room would possibly think that it's either or. I think we all must surely agree, in this room at least, this is, I think, a little bit of an echo chamber, that we really do need to pay attention to both of these very important determinants of human health and the inequities in how human health is experienced in subgroups of the population, but also between populations. I think it's also important to recognize that social justice isn't just about our contemporary times, and I think the point that was made from our commentator from Canada, and I've just come from Canada this week, where you constantly hear invocations of historical trauma. So that's another very important point. It isn't just in our times, but also in the times that have gone before us. However, I kind of wonder to myself, and I invoke my own experiences here working in the mental health sector, is that I'm often challenged when I talk about interventions for people with mental health problems. I'm often challenged with the idea that you cannot understand mental health problems without understanding people's lives, their social conditions, not only here and now, but as with the indigenous peoples of North America, the social conditions of their ancestors as well, and the dispossession. Of course, you hear also very similar accounts from when you consider the mental health of groups like African Americans. And that still confronts me with the fundamental question, how do I deal with this particular larger social construction of ill health if I am a frontline provider sitting in a health center? Is it the case that if we were made to argue about addressing social conditions, that the reason for that is to improve health alone? I personally don't think that is the reason. If we have to address social injustices, it seems to me that's an end in itself. Obviously, the fact that these will also produce benefits to human health, particularly for those subgroups in the population who've been historically disadvantaged, then that is a wonderful thing to celebrate, on top of the fact that these injustices are in and of themselves something that all of us, no matter what our professional persuasion is, must combat at every point of our lives. But I think that's a different conversation in my mind from the conversations around universal health coverage and issues around equity in universal health coverage. I think when I think of the issues of universal health coverage, my sense is we're agreed on most things. Firstly, that the visionary definition, first of all, I have to say one of the great discoveries for me at this workshop was the historical lessons. And I would like to thank you for, Socrates, for showing us those quotes from 1976 or 1974, when I was just over 10 years old, which really reminds us that actually the vision of primary healthcare that Mala has was so grand. And if I look at what was written on that slide, I think we're really discussing very much the same vision today. And it is ironic that when Alma Ata happened, there was already a chipping away of that vision, as I understand from your narrative. And ever since then, actually, and I say it's ironic because we adopted this idea of health for all way back then in 1978, we've seen a progressive chipping away with the arrival of a much more narrower technocratic view of what should be provided under the guise of universal health coverage. And I think in some ways I can draw on my own lessons of working in the mental health sector to think of how that has affected my work and the strategies that I've taken and where I hope we should be going forward. Just to remind you all, I work in the area of mental health. And it's very interesting that we are now in the era of the Sustainable Development Goals, and one of the great catch-all slogans of the SDGs is to leave no one behind. But I can assure you that no matter where you go in the world, including right here in the US, the one community of people that has always been left behind are people with enduring mental health problems and disabilities. And we've heard little bits about that in the last day and a half, but I want to say a little bit more. Even as early as the 1960s, we already knew that this was a historically disadvantaged group of people in every community, that they had not only the disadvantage of a very enduring health condition, but oftentimes those disadvantages were very deeply intertwined with social factors, not least, for example, historical trauma, but also traumas related to actually experiencing the mental illness. However, we're armed with all the evidence that we had about suffering, just plain human suffering. I still remember an occasion where I was confronted by a group of economists at the World Bank, and that was in 1998. And I remember it well because that's when my direction of the work that I do took a real significant turn. I was faced with this room where we presented all the burden estimates. By then, we had been armed by data from the Global Burden of Disease study, which actually surprised all of us, I have to say. It surprised Chris Murray a lot, but it also surprised those of us who worked in mental health when they reported that mental health conditions were amongst the leading cause of the burden of disease. And one reason they were amongst the leading causes was because they were health states that were valued the worst by communities. So I'm sure you all know how these DALYs are calculated. It's a bit like a sausage machine, but one of the things that goes into that calculation is asking people to compare different health states. And on that basis, they allocate a disability valuation, and then that's used to calculate DALYs. Schizophrenia was valued as the worst health condition, even worse than paraplegia. And of course, we can go into discussions about this, but nevertheless, I presented this at the World Bank. I said, not only are these conditions associated with all these human rights sufferings and social disadvantage, but they're also, if you approach this from a community perspective, the conditions that people in the community consider amongst the most difficult to live with. And I was faced with this challenge by these poker face economists that that's all very good, but you have a cost-effective intervention for these conditions. And so I began a journey of trying to generate evidence on how we could actually support people with these chronic enduring mental health conditions in India in particular, but also with collaborators in many African countries. And what happened then was that you realized, you knew right at the beginning that in fact what a person with schizophrenia, and I could extend this to dementia, I could extend this to autism, I could extend this to palliative care and a variety of other chronic enduring conditions. What they need is a lot more than a narrowly defined health intervention or a biomedical intervention, which is actually what, unfortunately, was really the most likely kind of intervention to be evaluated in the formal sense. What they often needed, for example, were things like better housing. They needed a combination of healthcare interventions that also addressed comorbidities, physical health problems, and so on. But this did not this could not be accommodated within the cost effectiveness formulae that I was being taught to use. And so what resulted was a narrow redefinition of the intervention for people with schizophrenia that only focused on antipsychotic drugs. And that, in fact, is where we are today. What is now being promoted under the guise of universal health coverage for serious mental illness is access to antipsychotic drugs. And when people talk of antipsychotic drugs, it is the cheapest antipsychotic drug that was available 50 years ago and which almost no one in the Western world or North America would ever be prescribed today. While we are now confronted with the fact that people with this serious mental illness die about 20 to 30 years earlier than they should, even though the condition they live with is not in and of itself a lethal condition, the only reason they die so much earlier in their lives is because they do not benefit from this vision of universal health coverage that we've heard about today. And that, in turn, is because the way interventions are being defined in this universal health coverage paradigm really misses the broad biopsychosocial nature of mental health problems. Indeed, I would say of all chronic health problems. This is an interesting word. Many of you may or may not be familiar with this, but I remember way back in the 80s when I was training as a psychiatrist, this was actually a word that was very widely used, biopsychosocial. The idea really was that all mental health conditions can only be understood by really taking into account all three dimensions of our well-being, our biological makeup, our psychological makeup, and our social world. What we're really left with as we think about universal health coverage and the way that it's being promoted right now is just the bio, and the psychosocial has almost completely been removed. And I do worry about what's happened as a consequence. The consequence of this is that the psychological and social needs have essentially been farmed out. Farmed out to whom? To NGOs. So it's become a charity activity. Or to religious organizations, which also is in the guise of a charity activity, or indeed to families. And by families, of course, this is not to mean that families are being supported in any particular way, but they're really left to their own devices. And in fact, I would say, and I know, Arthur, you worked a lot in this area, that in most parts of the world, 99% of the burden of care, and I use the word burden in a very broad sense here, for cancer, for palliation, for a whole range of chronic disabilities and enduring conditions is on the family because they do not fit in to our narrow view of what should be financed. Now, I want to end with I want to just give a very quick additional example of something that happened to me just last month. I serve on the World Health Organization's Independent High-Level Commission on NCDs. And in our final sign-off meeting in Geneva, a colleague who I won't name, but who has a very strong expertise in a more narrow technocratic view of NCDs, basically recommended, this was a report that was to be released at the UNGA, that the approach that all governments should be recommended for NCDs and mental health should prioritize the usual four things, smoking, exercise, etc., plus the treatment of hypertension. That was the only care intervention that was included. And there was a moment of silence in the room there because most of us were like in the age where half of us probably had diabetes and probably the full room knew someone with diabetes or cancer. And somebody gingerly put up their hand and said, well what about treatment? What about care? So, well, that doesn't fit into our model. This is last month at the WHO. And it was very obvious to me at this point that we really, really are so far away from the sort of vision of universal health coverage that we are sitting here in 2019 and still focusing only and almost solely on prevention. By the way, the hypertension thing only creeps in not because hypertension is a health condition, but only because it is a risk factor for something that might happen 5 or 10 years later. I want to finish, and I know time is out and there'll be a lot to discuss about this issue that I think we're all grappling with, and I think that should be the issue. Is how do we make health something that is, we've argued and we all acknowledge, is something worthy of investment in? How do we mobilize more resources? I personally reject the idea that the envelope is fixed. And the fact that we have always worked with that assumption in our public health way of thinking, that the $32 in Ethiopia will always be $32, that it is not an elastic number that can be expanded, and there are many ways that we can think how our resources can be allocated, is for me one of the most important lessons that I've taken away, not only from my work, but also from this particular workshop. And so that would be, I hope, what we can discuss next. How can we enhance that envelope? But also thinking about India, and this is my last remark, how can in countries like India, which are no longer reliant on external assistance for the health sector, how can we use the money that we are allocated for health in a more sensible way, in a more efficient way, but also in a way that maximizes quality of care? Thank you.
So while the slides come up, first of all, let me start by thanking Aaron, Scott, and Salman, and all the other organizers. And I think we've had a tremendous and very fruitful day and a half of discussions. And while you all are relaxing after your presentations, my level of anxiety has been rising since I have been tasked with facilitating an discussion at the end of our sessions about what ideas we have options moving forward, which is sort of like the sentiment and that is been trickling now. And you can imagine how difficult that task is, given that I have former students, that I have current colleagues and friends, and former esteemed professors and world leaders in this same topic. So I'm supposed to try to do a participatory class to get your insights around how to move forward. So feel like as students again that we want to walk us through really what it's been circling this morning of what do we do next with what we've discussed, and how do we take into account history to not repeat the same mistakes, and probably to have a more conscientious understanding of where we are right now and the challenges that we are facing moving forward. And in order to do that, I want to bring to you 3 images that I hope help us keep in the back of our minds where we are right now. This image comes from the Latin American Social Medicine Association that I'm part of a year ago, the last conference in La Paz, Bolivia, that ran at the same time that the Astana Conference was being signed, and the same day that the Astana Declaration was being put forth. The Latin American Social Medicine Association, as this image presents here, said, in order to advance our right to health, we have to say no to universal health coverage. And we have heard a lot about that. So let's keep that, what this crazy Latin American country mean by rejecting forcefully universal health coverage. The second image, I want to bring again Jean-Claude Mugungas with his wonderful presentation yesterday, and the sense that the few selected services are coming from the perspectives of not the people who are living in that. And we heard from Daniel Allen that this is the rational technocracy serving the interest of the donor states rather than the recipients. And yet Claude told us, nothing for us without us. And Mary Jo also brought up that quote. And this one, 2 days ago in The Guardian, this piece of news of the massive revolts that are going on around the world, in which people are feeling in the verge of collapse. And whatever little they take away from the social welfares or cost are pushing people to protest on the streets. And so with those 3 images in the back of our minds, I think I want us to think about the agenda moving forward. And I'm proposing that what we've heard in this day and a half can be grouped in 3 large sort of themes or orientations that should guide our discussions. And this is my proposal. So first, I loved the way the conference really brought the historical piece, and we've heard how Alma-Ata has now multiple new interpretations and reinterpretations of what it means. And we know now that it's a big, tense, and polysemic concept, that it can be a gold standard for a political statement for global aspirations. It can also be a practical approach to improve health inequities. And it can be also a source of inspiration for meaningful, comprehensive, and a political form or a politicized form of healthcare. And at the same time, we heard just yesterday and just today how Alma-Ata was already a minimized and colonized statement that even uses and continues to use the global south as sites of post-colonial racist experimentation, right? And so perhaps similar to the take charge of the Negroes that we heard in the first presentations, and how for-profit global health policy and global health sciences continue experimenting in a racist way around the world. And yet also, thank you, historians, and I think the important part of this historical piece is not to think back, but to think about what does that mean in the present times, and how we continue with a racialized global policy assessment of what we should be doing. And I think that's the big challenge of technocracy that historians are putting us forth. How do we confront, keeping in our minds the neo-colonial and neo-imperial configurations of global health moving forward? And that's the way I want us to think about when we think about history. The second big trend that I saw was framework. And it was very interesting to see how with the framework, the concepts are really contested. And we saw in this conference that there is a constant ongoing struggle for a meaningful definition of equity and justice in health. And Vikram just talked about that, right? So we have challenging conceptual definitions, and we are even doubting the utility of some agreed upon concepts, not because of themselves, but because they are very easily co-opted by emerging concepts or neoliberal platforms as universal healthcare, coverage, or primary healthcare. So I think in terms of the framework, we are receiving an invitation to really unpack the meaning of several taken for granted concepts, such as catastrophic expenses, or we just heard about political will. What does political will within a global neoliberal economy and imperialist agenda? What does suffering or health and care and healthcare mean, and how it's that being constantly redefined in a specific also context? And we had then here some specific ethnographic and qualitative examples of sexual reproductive rights and care and mental health that really then bring this issue of how those concepts are really context specific, and we also have to think about that. But in terms of the framework, I think Sarah Whelan's concept of idioms of social justice mobilization also gets to the core that there are many ways in which we can advance this platform, right? But we have some restrictive idioms, and we've heard a lot about vertical, reduced approaches versus comprehensive and more expansive approaches towards health. And then in this issue of social justice and mobilization idioms, I wonder if progressiveness is the answer. And we heard, for example, in our keynote, Danielle Allen's, the politics of rights expansions. But then I think the question as well is, how do we define progressiveness, right? Is it a technical or a political discussion of progressiveness, right? And I think we just heard as well how the technical has to be subverted under the political, and the importance is to advance a political discussion of progressiveness, and perhaps, and we heard a lot, what's a decolonial approach to progressiveness? And I think that's part of the agenda. And the third part that I think we heard a lot quite this morning was the strategies. So what do we get there? What kinds of healthcare system or set of broader strategies, not just around healthcare, that relocate budgetary priorities at the national and global level? And I think that's a little bit of the sentiment that I hear we ought to be discussing, right? So we know that healthcare services need to be effective, efficient, and responsive at all levels of care. And then the question is, according to which colonial or neo-colonial history, so that we can, as we just heard as well, how we redefine the international economic order so that the best strategies are possible. We need then to challenge power and be creative, right? So, for example, we had a very interesting discussion about healthcare expenses, right? And here I take and I draw from my own activist academic work, inspired by ACT UP, inspired by Anne Manuel, inspired by Joya, inspired by Partners in Health, and many more people that are here. I was also sitting when the Colombian chapter of the People's Health Movement was signed in the Colombian Congress, and we heard about a tribute to David Sanders. But I'm also part of the Latin American social medicine tradition, and in a way, Brazil, for example, was able to challenge this limited cost understanding by negotiating with big pharma the prices of antiretrovirals, but also by promoting a strong platform for a national industry of generics and even to break patents. And I think that's a very important example of what we need to be discussing. At the same time, I'm a witness of the catastrophic devastation of healthcare and other epistemologies of care under privatization as it's happened in Colombia. And so we are arguing, I think, that healthcare does not need to be expensive, but that it has been made expensive through the for-profit sectors that benefit out of providing care. And we heard yesterday that costs are not fixed, but are social constructions in which a big part of it is profit. So perhaps we should be talking about that. What's the margin of profit that is acceptable for a global emancipatory agenda around global health? And so we think that the issue here is, do we keep on talking about technocratic rationing of resources versus redistribution, but not only of resources, but of power, right? And whether political will or international solidarity that we just heard of are the answers, or would really tackle the discussion about colonial and neocolonial reparations, right? And then who should be talking and decided, and what actors? And we heard also a little bit that perhaps we need to continue working with top people, heads of the state, WHO, international aid, international financial institutions, right? Perhaps they are still need to be part of the table. Or do we need new global actors? Let's think about that. And definitely we need the community-based strategies are very important when we bring to the table, right? And so we know that there are upstream social determinants, but perhaps going off with Jean-Claude's statement isn't the biggest historical determinant of health, of existing inequalities, our colonial history. And then what do we do with that, right? And Eric said, scrapped the patent system. And so can we get rid of profit in healthcare, for example? And if we agree, then why is not that part of our strategic plan? How are we putting it on the table? And I think perhaps here we could also think about a little bit of issues of decolonial theory, right? If what we have get us here, why are we insisting that the same strategies are going to get us out of here? And that's what the colonial theorists say. So in order to facilitate the discussion, I want to open up the floor to you, my dear students and expert colleagues, and throw to the table, right, what we envision moving forward, right? You are the experts in global health. Let's imagine, as Salma was saying, there is a pamphlet, there is a statement, there is something coming out of it, or just taking with us, right? And what would you like to see in that? And what, being, embraced, and what would you like to be really being harshly criticized, right? And I think when we think about history, I think that we should think about colonial and neocolonial history in health. When we think about the framework, it's meaningful definitions to achieve justice. And when we think about strategies, there have to be creative strategies that not only challenge, but transgress and perhaps invert power. And that's where I want this group of experts to throw a lot of ideas as we close. Let's leave with that sense of we're going to move with the agenda that we set up to fight for when we started this meeting. And I hope that capture what you wanted me to do, plus now the very interesting participatory discussion that we have. So I'll call up hands, and someone please take notes that I can't do that at the same time. And we need microphones.
So this has been a fascinating session this morning. When I came here, I take all notes on notebook. And so I entered in Reconceptualizing Health for All. And I noticed that it was on a list of revisiting historical space, rethinking global health governance, which held here, and so on and so on. We do a lot of revisualizing, reconceptualizing. One of the things that struck me about this conference is that so many of the ideas that came up have been talked about before at earlier conferences and led to the publications of edited collections. And I said, how do you get out of that? Because I guess it's the frustration of having talked about this stuff for 30 years and we're still here doing it, now. And it's not clear what the solution to that is. I was thinking of, in the 1990s, I was working on my TB book in South Africa. and I was sitting around a table with a group of labor historians. And I said, "You guys are really critical of the government. How do you stay out of jail?" And he said, "Well, as long as we stay in our academic circles, they don't care because they realize academics are really powerless. It's only when we, yeah, it's only when we cross the line and start working with labor that it becomes dangerous. And as you say, you end up on the bricks, or as David Webster tragically was killed because he moved from being a sociologist over to being an activist." I don't think that's really what we're facing, but I think that's where we need to be going. And I think that panel today was absolutely central to that notion that, as Daniel Allen said, we need to get out more. We need to make allies. We need to get the message outside of academic circles and into the field and find ways. And that's not easy because, as she also pointed out, we talk in a language doesn't necessarily translate to people who are working out in the field. But if we're going to move forward, we can't do it sitting in these rooms, and we have to figure out that. And so I think the most central thing going forward is how to take these conversations outside of here and find the allies and make connections.
Thank you. Joya.
Thanks, Cesar. That was a fabulous summary and pivot, I would say, to really looking at inverting power. And I think what is our role as academics? And again, I wear both hats because I'm still a practicing clinician. But I think working with communities, working with people who are suffering and oppressed, and asking, what, with my power and privilege and the hats I wear, I can do to help you. And again, when I asked Eric that years ago, it's like, show us that it can be done so that we can work together with you, right? Or show us, cost out this strategy so we can fight for an envelope of money that's real. So I think rather than assuming we know, assuming we can be useful tools in a movement, to me is a very powerful idea, because it really inverts the power, because then my skill set is really being used by the people who most need it, rather than for my benefit or for the benefit of just generating knowledge.
Mm-hmm. Here and here. And then.
Let me make one comment and then a question. What can academics do? One thing we can do is not allow doctoral students to do their work on other people's data, that everybody who actually does get a doctoral degree has to go out and collect the things in the field and go to the field and see what actually is going on. There's far too much using OPD, other people's data. So that's one small suggestion. I'd like to ask you, since we've now ventured into Latin America, why is Cuba not brought forward more aggressively? After all, they have, as far as I can tell, UHC. They've followed a particular model that not all of us, not everybody likes. They have one of the largest medical schools, if not the largest medical school in the Americas. What have they contributed, especially within the Latin American context, into this whole area?
Mm-hmm. So let me just answer that quickly, and I'll take the floor. Indeed, the Cuban example has been one of the central points of the Latin American social medicine movement and tradition, and it's sort of the founding fathers, and talking about ideology, right? Like Salvador Allende, and when you talk about the bridges and exiting academia, right? The first socialist elected president physician that then was being murdered or led to the assassination, and then Che Guevara are two iconic figures in Latin American social medicine movement. And I think, as we heard also as well, we don't need to engage in the conversation of coverage when we have a robust healthcare system that it's publicly funded and that reaches all levels of care at all people and all settings. And that not only happens around healthcare, but around education. So Cuba is set up, right, as the example sort of that has persisted, and has persisted not just as how cool it has persisted, but with it a big political embargo, and we're under, very harsh conditions. So I think from Latin America, there is a keen eye of Cuba to take as an example, and it has benefited a lot, even with the, Latin American School of Medicine that a lot of people are. So yes, that's kind of a contrast that we have constantly have. There was one hand here and then one here.
Just on the sort of creative strategies and inverting power, very much encourage people to get engaged in the debate going on in South Africa at the moment. There's a tremendous opportunity for the South African health system to sort itself out and become more equitable. It's spending 8% of GDP on health, but half that spending only goes on 16% of the population who have private insurance, and the rest of the population are it's grossly underfunded system. And not surprisingly, the vested interest in the private hospitals and the pharma and the big insurance companies are throwing everything at the South African government to say this is terrible and is a mistake, and they're getting battered in the South African press. And I know for a fact the South African government would really welcome academics going to South Africa to say, no, this is the right thing to do. This is what's happened in Latin America. It's what's happened in Europe. This is a logical thing that you're doing here and will be good for the economy and good for the people. So I think, for all of us collectively to be looking for countries where there is the opportunity to all come together and help them over the line. And then, sort of progressively, we'll sort of get more sort of countries with socialized health financing systems that we're benefiting from.
Yeah, thank you so much for this closing and for this really wonderful set of discussions over the last 2 days. My name's John Shaffer. I'm a PhD student in sociology at Boston University, and I think that we've talked a lot about the need for a broad-based social movement for basic social and economic rights and the right to health. And I think as a student of sociology, I keep going back to where are there great examples of social movements and who brings the tools of social theory to analyze social movements from a structural, cultural, and ideological frame. And so I wonder, whether that can be, an opportunity for future engagement, really thinking about transnational social movements in serious ways when we think about the right to health. And also one distinction that I wanted to offer between activism, which I see as kind of momentary, loud, visible, punctuated, compared to community organizing, which tends to be slow, deliberate, strategic, often under the radar. And what kinds of investments and opportunities we are taking to analyze grassroots community organizations as vehicles that create spaces and opportunities for activism that are truly strategic and can create new kinds of politics. So just two ideas.
Great, thank you. Vikram.
In terms of alliances, I think another group that some of us belong to but don't necessarily engage with is the medical community. I think the issue of power in many parts of the world is vested very strongly in the medical community, and this is also to do with your point, Rob, about the private sector, which is also very heavily invested with the medical community. How often do we actually get the professional societies on our side? And I'm reminded of the opioid epidemic here, which in part, although we're blaming always the drug companies, the drug companies didn't actually prescribe a single opioid drug. And I think the fact that the American Pain Society today is no longer in existence, but was one of the most dominant medical societies in this country, is a testimony actually of the collusion of medicine as an organized system in its own right. And I do think many of us sit in both camps, and I would suggest that those of us who do must get these professional societies to begin to see the world in this way.
Perfect. Right. Eric?
We were talking a little bit yesterday about nationalizing the pharmaceutical industry. My fantasy is that, that's done on a global basis, and that we basically take away the research and the development, the funding of, essential medicines from the profit margin and from pharma, which is, the evilest empire that I can think of. It just, since the beginning, I was outraged that somebody who'd been infected in the 70s, symptomatic since 81, could survive decades and decades and decades because I had access to ARVs. And, from that day forward, it's gotten, it's just gotten in my soul. And, nothing enrages me more than to know that there are, life-saving medicines for, diabetes, for Christ's sake, or, antibiotics that are being denied people around the world. And, there should be a movement to basically take those essential commodities out of the private and profit sector and get them to people everywhere.
Mhm.
And if there was a single movement that I think that needs to happen globally, that's it.
And Emmanuel.
There is, of course, a certain paradox or irony that here we are, the hubris of being at Harvard and operating in the royal we mode as to how, with the platform, wonderful platform that CESAR has presented, that we should somehow come forth with an agenda or action plan to grapple with all of these issues. Um, let me just comment in three arenas here. I mean, I very much agree with the idea of solidarity and folks who are privileged enough to either be working in the global north or in institutions within the global south that afford us spaces in which we can be in solidarity. And here I don't think scholar activism is a dirty word or a dirty term, but actually, I believe it's the only ethical way we can engage in academia and the privileges that we hold and go forward. Now, there are various ways of learning. I mean, Socrates asked about, the boxes, what can we learn? Cuba is an incredible example, not only of the way in which its healthcare system evolved from prioritizing poor rural communities first, right? But also in its engagement in South-South cooperation. It was the first and most long-standing country. I mean, went into Algeria immediately following the very brutal, bloody liberation struggle from France, and helped to, with Che Guevara, in fact, at the center of this, helped to rebuild the Algerian healthcare system. Its medical school of the Americas, ELAM, has trained literally tens of thousands of doctors and other healthcare workers. Tiny Cuba, with its tiny GDP, has on its own countered the brain drain that has been caused by my country, by the US, UK, Australia, and so on. So, if we could have a lesson of this kind of solidarity and the health cooperation that is horizontal, that puts the agenda of the cooperant first, not as per the 1961 US Foreign Aid Act, privileging the needs and advantages for and priorities of global north countries. And just my last point has to do with how we engage in global health equity, quote unquote, without a passport. We have a little section in our global health textbook which looks at how much we should be involved in wherever our countries are, speaking truth to and about power, and the ways in which we do that. And I can speak from a Canadian perspective, what People's Health Movement, which is a group of both physician clinician activists, academic activists, and community activists, have done is tried to take on mining transnationals, most of which are based in Canada and my own city, Toronto, and use that as our rallying cry. How can we work in universities? How can we work in a country that gives the green light to extractivism with very easy access to capital, almost no judicial recourse, et cetera, et cetera? And this one thing that we could do to stave off the terrible exploitation in Ecuador, in Bolivia, in Tanzania, et cetera, I think it behooves us all to start at home in that regard. Thank you.
We have one person here.
Thank, thank you very much. For that. I was very interested in an idea which was presented yesterday about a metric, or thinking about new metrics in terms of increasing the local capacity to save lives. Which I thought was a good and new way of looking at actually how to do local, like community level intervention. Now, speaking as an anesthetist, there's a whole global movement going on about, unmet surgical burden, safe surgery, and things like that. And part of it has been included in the universal health coverage. But a lot of it is coming in from above. There's very little of it is actually integrated from below in the local activities actually below. And I think that is one way where this whole global movement on primary healthcare can actually incorporate that, which is actually not happening at the moment.
Sorry, I just want to make a comment just to build on the responsibility of academics. It is true that we are in a special place, and certainly a place of luxury, being able to sit in a room to discuss this. But I think also part of that responsibility is to really change action, or work with people to change action on the ground. And I'm just thinking about our group's experience, certainly in primary healthcare, with Joya touched on, working with different countries like Rwanda, like Haiti, et cetera. But most notably in the area of TB, in not this room, but a room down the street at the Academy of Sciences, the suggestion that you would only treat one kind of TB was challenged, and that resulted in the creation of different programs, and the idea that you have to do active case finding and treatment of latent TB and treatment of all forms of TB and patient supports, and it's growing. And it's something that, I think you're able to change from here. And what I would want to see come out of this discussion, since we are in a place of luxury that we can actually think broadly, I would imagine that we would want to say, yeah, if you have universal health coverage, you need to have pharmaceutical supplies at a really reasonable price, at a fair price. If you want to have universal health coverage, yes, you probably need some pooled risk mechanism, and it could be through the private sector, but it has to be highly regulated so that everybody can access it, and maybe state financed, et cetera. So I think that there is something that could come out of here, because I think what's happened is a room full of people just like us met in New York and came up with something that is substandard and not satisfactory. So a room of people like us can say, we just don't think that that's right. We think that some of the values that were brought up, say, we've just heard from Socrates pre-Alma Ata, though watered down in Alma Ata, even those are fundamentally at risk if we move forward with the path that has been set out by people. And in both cases, both in this room and in the room in New York last month, the voices of the people who are suffering, the marshals, are not there. And so in some ways, I don't think that it's a crime for us to leave here and say more voices should be heard, drug supply should be available, X, Y, and Z, has to happen. And this idea of a closed envelope in the $35 or $60 or $100 is hogwash. These are the dimensions that need to change in order for us to be able to actually do universal health coverage. Or else we end up with what Aaron talked about at the very beginning, this doublespeak, where everyone is saying human rights, human rights, human rights, but some humans get crappy care because they've got an envelope of $35.
So what's happening in some universities, I think I've heard about it here, but also in Scotland, is that they're commissioning people to do historical analysis of the way that university benefited from the slave trade. So for example, even if the university didn't directly own slaves or sell slaves, as I believe, was it Georgetown became famous for doing that? Even if they didn't directly benefit, many of the universities I know mainly about the UK, but I believe it's more common than that, that they benefited from endowments from families that benefited from the slave trade. So by having, and you could extend the slave trade to colonialism, etc. It's probably, the data is probably easier with the slave trade. And then having some kind of consensus about how they can attempt reparations from that. And I know there are difficulties with reparations. That, you know, if you give students, preferentially give students scholarships, you don't know if those students will then benefit back their country. But some discussion around reparations that includes a recognition of how institutions have benefited from disadvantaging countries. Yeah, I think that would be, that would go a long way to making people recognize the injustices and, well.
Right. Can we have more?
On following up from what Salman was saying, and there's, I'm not sure if we are making a statement or you're sort of taking points forward like this, but to pick up on something you said, Salman, but for us to be much stronger, I think you said something, you know, we might need some pooled system where, you know, the state might finance or so. I really, yes, far too. Yes, to be perfectly frank. And last week or 2 weeks ago at the UN General Assembly, I've got the quote here. Gro Brundtland said, you know, that speaking to that opening plenary, if there is one lesson the world has learned, it is that you can only reach UHC through public financing. And I think that we should say being that loud and clear. Now, it's not to say that there might be some private financing, complementary financing on top. But if we're serious about the goal of UHC, factually, it's correct that no country in the world has done it through a market-driven, privately financed system. And I think to sort of help countries see the wood from the trees on this would be very useful. So, you know, I would love to come from this, you know, August meeting in Harvard to say that this is agreement with that statement that you can only reach UHC through public financing would be a very useful thing to come out of this. Thank you.
Joy.
I was trying to be nice, Rob, but you're right. It is wishy-washy.
I think we have to recognize one huge elephant in the room, at least for the most impoverished countries, is the United States government. And our colleague Jean-Claude Mugunga, who many of you met yesterday, was at a meeting at USAID, and the NGOs are actually saying UHC is a great business opportunity for the private sector. And I think we need to really recognize that that is the countervailing weight to what you're saying, Rob. And, you know, when you look at Colombia, which Cesar knows far better than I do, but we shared a graduate student who was looking at the provision of emergency care, intensive care in Chocó, which is the poorest and most Afro-Colombian state. It totally depended on what level of private insurance you have. And Colombia is touted as having universal health coverage. So, you know, until we get people to square on what this language means, you know, and holding up Colombia as some kind of, you know, panacea when it's all privatized and highly unequal and does not provide care to everyone, and address this sort of still very living, kicking and breathing Washington consensus of privatization, we're really not going to win.
Anybody else?
Just one thought that came to mind of a group that's doing organizing work, I think very much along this vein, is the Social Medicine Consortium, which maybe some of us know about, and obviously, but I just wonder, you know, how that community and their voice could be part of these types of discussions going forward.
That's an important point. You know, this is the danger of the Joya's point. Sorry, just to jump from the community back to Joya for a second. I mean, this is a major issue because, you know, even in the TB world, in every sphere, the United States gets up and really wants to make sure that there's access to markets, and you know, obviously, and Rob, you can speak to this more since you do this full time. But you know, there are ways that the markets are involved, obviously, in places like Germany and Switzerland and the Netherlands, et cetera. And and they're very regulated by the state, and the state is paying the fee so that all citizens can get in, or citizens are paying based on their salaries or something, so that there's a way that everyone can get coverage. And so I think, and unfortunately in the US, that's not the model, and that's defining what we're recommending for the rest of the world. And again, another place that people in this room can say what you're saying, Rob, and I was saying in such a wishy-washy way, that, it has to be, regardless of the exact mechanism of distribution, it has to be publicly financed, and it should be distributed based on people being human, or people being citizens, or something other than their ability to pay. It should be distributed based on need, as you've suggested in your talk earlier. Like fire services, yeah, yeah.
Publicly financed in India. Public money into the private. Publicly financing in Lesotho. That burden, which is 51% of the entire health budget, that is going to a for-profit company, Netcare, and not providing care to the Basotho people. So I think we have to be very careful what publicly financing is. If it's just the public assumption of debt or public financing of the private sector, I think we've got to push way harder than public financing on what is the mechanism of distribution.
Any thoughts on that?
I agree.
Yeah. No, I would just add a word.
I think the real problem, Ayushman Bharat, is exactly what I think Rama spoke to. That before, when the insurance premium was set at, let's say, because people don't understand the word lakh, let's say it's $100, then medical hospitals would charge exactly up to $100 for a cesarean. Now that it's $300, they will charge exactly $300 for cesarean. They work entirely on how much you can get paid. They will charge that much, and it'll rip the budget out from the heart of the public health spending. So I agree with you entirely that there has to be a accountability, really, in how money is spent. That is not to mean that I don't agree with the role of the private sector in provision, but only if they are held strictly accountable in exactly the same way as the public sector is being, so there's a level playing field.
Well, are people in this room interested in us thinking of how we could push the agenda on UHC and just coming up with some ideas that we circulate with each other? Just, because again, we've had a group of people come up with their ideas last month, and here we have a group of people who've been thinking about this for 10, 20, 30, 40, 50 years. And so, and more. And, could we, maybe come up with some thoughts that we think should be on there, and that could be something that comes out of this meeting. It may not be something that everyone agrees with, but hopefully it can be. But really pushing the agenda on what it might take to get true universal health care. Would that be something people would be open to? Yeah? Okay. So Aaron's already drafting it. Okay. Maybe it's a good... Yeah.
No, I'm just wondering if you have the earlier statement that you how does your statement then differ from that? Because I mean, I don't think many of us have seen what the earlier statement looked like
the
in New
universal...
York. Yeah. Yeah.
Yeah, it's not our statement. It's what the...
Okay.
So
I mean, I think could that be the peg where we sort of contrast what and contest and contrast that as an outcome of this meeting?
Yeah, a lot of people have referred to it, but you're right. We didn't look at it directly, and I think that would be a good thing to do.
Why don't we start by doing a critique of that statement and publishing it somewhere where it would be widely read? And then the second stage is offering our countervision.
Thanks, Audrey.
Yeah, that's a good step. Yeah. Aaron, you wanted to say something?
Well, it's funny because I think we've reached I think we've reached the moment in this conference that we did 2 years ago at another conference organized by the Initiative on Healing and Humanity, where we say, just after banging our heads against the wall for 2 days, in frustration and outrage at
that one was on accountability.
At the lack of accountability in global health institutions, we say, and considering the various possible ways that we could intervene, we kind of say, well, you know what? Is the solution evolutionary? Is the situation, one in which we actually can intervene, or are we in a revolutionary situation? And I don't mean to be radical chic. I think it's easy, as Professor Byrne said, to be radical chic at Harvard because you feel very, very empowered. But to be honest, I think that many of the talks today have really confronted that question. Particularly Joya's. All I could think of as she was talking was, wait a minute. If you follow these thoughts to their logical conclusion, really, we're not talking about health policy. We're talking about upending structures of power. And so,
But we'll start with the critique of
I do think that, I think that this critique is really important, but I also think that in making the critique, in making the intervention, it's important not to be constrained by, an assumption that things can't be fundamentally changed. I think Eric was speaking to this, to this impulse in a very beautiful and experienced way. Sometimes you have to say, well, the only way to do this is to remove profit from the pharmaceutical industry.
Yeah.
I think that if we make an intervention, we would be remiss if we didn't think in terms that are, in some ways, revolutionary.
Well, and I think we can, Aaron, you raise a good point. We've learned a lot over the last 30 or 40 years from the environment movement. The idea that you really have to not think in terms of nation states, you have to go beyond that. We now are seeing the rise of what's called the degrowth movement, which is just so completely, out there. People are saying, "What? No growth? How will societies function?" And it turns out that there are people modeling this and saying, "Yeah, you don't always have to grow and destroy the environment and do X, Y, and Z. There's a different path." And so I think you're right. We do have to be bold in what we're thinking. Maybe this is a good place to end then, Cesar. Do you think?
Perfect. Yes.
Yeah?
Yes.
Well, thank you for leading us in such a good conversation. So you guys, even though we were an hour and a half behind, we've only finished 40 minutes late, which is amazing. I want to thank everyone here. I realize, first of all, doing this on a Friday and Saturday, especially this Saturday, but also it's just so amazing to have people in this room who have worked on this topic so intimately. And the younger people over the last few years, but certainly some people have done it for half a century, and it's just incredible to be able to draw from that knowledge. So on behalf of Scott and Aaron and our center and our program, I'm just really grateful that everyone came here, and I hope even though we may not have agreed 100% on everything, I think we've had just some amazing conversations, and I hope that we'll be able to continue that. So thank you very much. And thanks also to Sue and Tim and Helena, who you guys have been hearing from by email and have been seeing, for helping us make this really happen. And as a final act, Sue told me that if we go across the hallway, there's lunch being served, so we can go there. So thank you very much.